Okay, I don't know what to say. Maybe we should just go home, I think, and not give our babies prophylaxis. But I think we need to think a little more. Let us open our eyes wide before we make a decision, whether we have infant prophylaxis or not. I want to thank Anna for these slides. I had some old slides. I appreciate UNAIDS has some updated slides, which has allowed me to share. And I think the point I want to make about these slides is the 120,000 babies or infants who are infected annually. That is unacceptable. And then the other point to make on this graph, the darker blue lines, or the shading, 84% are in sub-Saharan Africa. So I thank God I was given the opportunity to be on this side. Initially, I thought I was on the other side. I thought, how am I going to defend it? But now I can defend it. And as you can see, over the last 10 years, we really have increased the coverage of ART for our mothers, but we really haven't done very well in reducing the new infections. As you can see, 80% coverage, even some countries 90%, but we still have 120,000 babies born each year. As we're sitting here, as I'm talking, babies are being infected. Ask your neighbor, is that okay? And then this stack graph, which we all know, our topic is a bit complicated, the mothers who are virally suppressed. But if you look at this stack block, you can see that the ones who are virally suppressed are the ones in light blue, and they're actually very few. The transmission occurs in the population that is not on antiretroviral therapy, the one who doesn't take their treatment or is not identified as infected. But for this discussion, we're talking about those women. We have 1.2 million pregnancies per year in women living with ART, with HIV. The coverage is about 82%. Most of the women in sub-Saharan Africa, over 80%, breastfeed their infants, and the viral suppression ranges between 60 to 90%. However, this is the main, if you're sleeping, you can wake up now. The important message is, unlike my distinguished colleague who said U equals U, we know that in MTCT, U does not equal U. So that's the message. If you want to go back to sleep, that's okay. About breast milk, we all know maternal ART suppresses the mature virions and prevents replication in the blood. But in breast milk, the T cells are activated and they're easily able to produce active virions. There's also cell-associated HIV, either latently infected or activated. Virus-producing T cells are very prominent in breast milk. This is old data, 2012. So it's not something new. So my distinguished colleague, it's not something new, it's old. But breast milk B and T cells are activated and express high levels of memory and mucosal homing markers. This is just a schematic of how the cells get in the infant's intestinal lining, and if it's cell-associated, they also cell-to-cell HIV transfer. This is also an old study from 2005. Shapiro et al. Showed, despite the women being on ART, the vertical axis is percent, and the horizontal is ART, the first block, and then no ART. So we start on the right with no ART. The dark black is plasma RNA, the gray is breast milk RNA, and the lighter gray is breast milk DNA. And when you move to the left, or to the right on your screen, the ART shows that the viral plasma RNA is reduced on ART. The breast milk RNA is also reduced. But look at the HIV DNA. It's nearly higher than the no ART. We've also known that for a while, my distinguished colleague. Now, we've got ART. We have the Keshaborn and Ban studies. He presented a lot of studies, great. I also have a few to show. And the summary is The Keshe-Bora's ART band study also was comparing maternal AR2 infant nevirapine prophylaxis. And we can see that even with the maternal ART, transmission was 3.1 versus 5.9% at 6 months in Keshe-Bora. And transmission in band was 2.9% versus 5.9%. Again, emphasizing despite triple therapy, we're having transmission. And you may say, well, what percent were virally suppressed? The last study, important study, I think they call it the last study in PMTCT or EMTCT, a famous study, PROMISE. We always talk about the landmark HIVNet 012. I didn't present it because it was, you presented on my behalf, thank you. But PROMISE is maternal ART. And this was comparing maternal triple therapy to antenatal prophylaxis or randomizing to postpartum ART. So we see that in the secondary analysis, 8 infants were infected in mothers, or 1,200, approximately 1,200 mothers on maternal ART. 2 infants became infected. Obviously, the other 6 were also infected, but these mothers had undetectable viral load. Undetectable viral load is what we're talking about, isn't it? Okay, so now these 2 mothers, their graphs are presented. If you look at the vertical axis, it's the log maternal RNA, and then over time. And you can see the bold line is CD4, but the bottom line, the dotted line, is log RNA. Undetectable viral load right from delivery, but the baby became positive at 14 weeks. The second infant, viral load detectable at delivery, but was not detected the whole time after that. And the baby is positive at 38 weeks. Let me know if I'm taking too long to explain everything. Okay, thank you. Okay, thank you. I hadn't seen that. I thought we'd be taking too much time to explain the importance of postnatal prophylaxis. Okay, these are the dolphin study and the vested studies, DTG versus efavirenz. We all know dolutegravir, rapid drop in viral load, and it's actually more efficacious, but also now we're using it in our programming, so efavirenz is history. But what it shows, that there was, despite the mothers being virally suppressed, there were a few infants who became infected. 3 were in utero, so we won't discuss those that much. The 1 postmortem transmission, the mother was virally suppressed. The baby was positive PCR at 38 weeks. Negative at birth, negative at 6 weeks, negative at 12 weeks, infected at 38 weeks. Undetectable maternal viral load. Then the vested, which is Impact 2010, again, 2 infants became infected. Infant 1, not much discussion. Mother, not virally suppressed. But infant 2, maternal viral load was less than 40 copies per mil. I've heard from our Swiss colleagues, 50 copies per mil is the cutoff. I'm a little worried. Okay, I want to say infant prophylaxis is required for elimination of mother-to-child transmission. My opponent from Canada. I'm sorry I couldn't find a nice picture about Canada, but we do know. I apologize, it was my mistake. I should have gone on the net and looked, but I do want to say Canada is really a beautiful country. I think Vancouver is one of the most beautiful countries in the world, to be honest, personally. But I know it's very cold. So I think it may be that somehow our brains get frozen sometimes. But anyway, infant prophylaxis is required for EMTCT. These are my summary points. Undetectable viral load in plasma is not consistent with undetectable HIV RNA or DNA in breast milk. Point 2, maternal viral load blips may occur between a maternal viral load testing. We're testing, I heard from our Swiss colleagues and from my opponent, that monthly testing. It doesn't mean that in 30 days you won't get a blip. Cell-associated virus in early breast milk contain latent virus. This is easily activated in infants' alkaline gut. Now, drugs for infant prophylaxis generally have prolonged half-life. We've known nevirapine works even when you gave single dose. It lasts in the infant, it lasted a long time, and now we're giving it for 6 weeks. This isn't the topic, but we need to look about long-acting injectables for prophylaxis. If the baby just got Cabele, and they'll be set 2 injections for the year. Now, a substantial subset of women living with HIV are not virally suppressed postpartum due to poor antiretroviral adherence. And we've heard that already this morning. That's not the topic of discussion, but I think it is important to take into account the public health approach. We do have many, many infants who are born and exposed to HIV. The majority of our infants are mothers on antiretroviral therapy. The infants are exposed to HIV even when the mother is virally suppressed. That's the point I'm trying to make. But many of the babies are born to mothers who are not virally suppressed and not on treatment. But that's not the topic for discussion today. So I just want to remind everybody, you can tell your colleague today, U does not equal U in MTCT. We use the same picture, it's amazing. Do we want to save each breastfeeding infant? Yeah, we must say yes to infant prophylaxis. There's some references. I want to thank Professor Mary Glenn who reviewed the slides. But from baby Betty, she's saying, thank you for saying yes.